hands and ask questions or put things in the chat. Austin and I are going to take turns kind of providing some information. So each of us will monitor the chat while the other person is providing the information, and we can respond as needed, and either verbally or on in the text of the chat box. So yeah, as Amina said.
Yeah, so Adam, what normally happens is we do the presentation, and then after the presentation, we address the question and answers on the Q&A forum.
Okay, that sounds wonderful too. That should work just fine.
So it's nice to talk with everyone. I appreciate everyone coming in to listen with us this evening. Adam and I are both, as mentioned, emergency medicine physicians in the United States at Brown University, but have spent a number of different, Adam, in his case, years, and I've been to Kenya several times, including just the last couple months, working with healthcare and emergency medicine in Kenya. So we were hoping to kind of contrast that with how emergency medicine works in the United States and in the developed world, and talk about both the benefits and kind of downsides to some of that. So if there's nothing else, I think we can start. Great. Okay. So neither Adam or I have any particular disclosures, nothing to relate to anyone that we would have a conflict of interest about. So for kind of some subjects, we'll talk about what is emergency medicine, what does that mean, where did it come from, and how did it develop? What does that look like where we work in both high income settings, but in the United States? And then kind of what are some of the hot topics in emergency care, and some issues that get a lot of attention and research and literature to look at how are these best managed and what should we be doing or not doing in some cases. So emergency medical care has been defined as any unscheduled episode of care for an acute health problem. So within the primary healthcare system, people in general, the idea would be that wherever you are in the world, your health system has routine care, access to immunizations, regular checkups. But in the event that something occurs that requires urgent or emergent attention, whether it's something that's painful, something that's changed, something that you think needs a doctor or a nurse to evaluate, that would be considered emergency medical care. The approach to emergency medicine really requires a focus on a couple of different things. One is finding patients with critical illness, so the sickest patients, and then stabilizing them and resuscitating them. So identifying this patient has something that could potentially be lethal, potentially very dangerous, and identifying that they're having trouble breathing, or maybe they're having a heart attack, so things that are critically important to identify and start treatment on. Additionally, emergency medical providers are tasked with two things: diagnostic and treatment decisions. And that can mean different things in different locations. Even within the United States, different levels of emergency care can provide different levels of diagnostic testing or different levels of treatment. And really, the idea is that an emergency care unit, an emergency department, an emergency ward, whatever term you would like to use, is meant to be able to do some testing and do some treatment, and some proportion of patients should be able to be treated and then sent home and have outpatient follow-up, while another subset of patients will require further treatment and care. So they're going to require maybe an admission to the hospital. They may have to go straight to theater. They may require more, but the emergency department can't provide for all of those things. We want to be able to start diagnosing and treating patients and then get them to their next part of the health system, but we can't be the entire health system. So around the world, emergency medicine is developing. So it started, and I'll go through a timeline here in just a second, but it started in the 1960s in a few places, particularly in the US, Canada, United Kingdom, and Australia. But this is a map that came out of just recently released ACEP International report. So ACEP is the American College of Emergency Physicians. And there's a group that's really interested in the development of emergency medicine around the world, of which Adam and I are a part. And that group looked at, just asked for countries to report in on what is the state of emergency medicine development. And so you can see that East Africa had a fair amount of participation, particularly as compared to much of the rest of the world. And was included in that report. And the link on the bottom of the slide there, you can see this report if you wanted to review it. Kind of there's some summary tables looking at some themes, and we're hoping to publish this in the near future, kind of highlighting the kind of similarities and differences as emergency medicine is developing around the world. But to drill into kind of what we were hoping to focus on this evening, in the United States, emergency medicine developed out of what I see as where Kenya is today. Emergency wards were a part of the hospital that patients would show up to looking for help, but they were generally staffed by individuals, whether they were medical students, medical officers, or what we call residents, trainee physicians, or other people that would work a stint in the emergency department, maybe a few months, maybe even a year or two, and then they would move on to another job because there wasn't really a career path or a specialization that focused on treating emergency department patients. And so it was kind of just a mix of different people with variable levels of interest, but very few people that were engaged in long-term improvement and enhancement of the quality of care. So a lot of times people would start to learn how to work in the emergency department, would start to learn some of the ropes about something like, for example, interpretation of an ECG, and they would start to get better at it. And as soon as they got some knowledge and skills, they would then move on to another rotation or move to another part of the hospital. So emergency medicine, particularly in North America, developed out of a need to fill a gap in the healthcare system. So when we look at the other types of medical specialties, they've generally developed out of a specific surgical or medical anatomical region or a body system. So cardiology and the interest in the cardiovascular system, otolaryngology with head and neck surgery. You know, you can go through a long list, but most medical specialties have a anatomical kind of reference point, whereas emergency medicine stepped back and said we need to tie all of these different systems together and be able to deal with undifferentiated patients who come in saying, I have a headache, and we have to figure out what's the root cause of that and figure out what's the treatment and testing to help deal with that individual. So kind of a unique need required a unique solution. And it's a bit of an extensive timeline, but in the United States, in the 1950s, it was recognized that the emergency department was a really weak part of the health system. It was kind of an unorganized mess of sorts. And so in the 1960s, there were 4 physicians in one of our states, Virginia, that developed a staffing model for one of the hospitals. They said, we would like to dedicate our work to only working in the emergency department. And kind of around the same time, a couple of years later, there was a group in Michigan that had the same idea and said, we like the way the emergency department kind of flows. We're interested in working there and getting better at working there. And so around the same time, there was a report from the National Academy of Sciences, which is one of our health research bodies, that pointed out that accidental death and injury was a major issue that was really neglected in the health system. And so kind of this mix of published literature showing a need and a few physicians in a few parts of the country saying we're interested in filling that need led to the creation of the American College of Emergency Physicians in 1968, and then 2 or 3 years later, the development of the first emergency medicine training program, which was in Cincinnati, Ohio. So slowly out of the gate, there were a few programs that developed, and as of today, I think there's over 150 emergency medicine residency training programs in the United States. So over the past 50 years, there's been an enormous amount of interest and growth in this area. Within a decade, in 1979, emergency medicine was recognized as a medical specialty, which I was excited to learn had recently happened in Kenya a couple of years ago. And then there was a board, a group that came together and said, we will identify what it means to be an emergency medicine physician, and kind of set up the board certification and monitoring and evaluation process for that. And not long after that, in 1989, the International Federation for Emergency Medicine developed in part from the United States, as well as Canada, Australia, and the United Kingdom. Briefly, the medical training and education system in the US is slightly different. It's somewhat unique, even compared to some of those other North American and European countries. But in the United States, most people go to university for 4 years, get a bachelor's degree, and then go to medical school, which is 4 years. And then individuals that want to pursue training in emergency medicine will pursue either a 3 or a 4-year program. There's kind of a mix, and there's some advantages and disadvantages to both of those that we won't really go into. But subsequently, individuals have graduated from their EM residency. They're eligible to practice emergency medicine. So they take a licensing exam and can get hired as an emergency medicine physician to practice independently. It's important to note that emergency medicine training, that green circle, is a supervised practice. So all the patients that a resident trainee physician would take care of is in tandem with a board certified emergency medicine physician supervising them. So there's less autonomy than maybe in some other health systems and training programs in the world, but it really does help lead an emergency medicine trainee in our country from kind of an apprenticeship into independent practice over those 3 to 4 years. Subsequently, individuals can pursue a variety of subspecialty training programs. It's kind of a long list, but it's not exhaustive. There are a few other things people can pursue, but most of these are 1 to 2 years. A couple of them are a 3-year situation where you would need an extra year. But by and large, they are for niche interests, whether it's toxicology, sports medicine, pediatric emergency medicine, critical care, these different things that if someone has a particular motivation and interest in, they would then go and pursue additional knowledge and skills and practice to then move on and be an expert in that area. So to talk through what it looks like to work in one of our emergency departments, it's a little hard because you can see so much even from walking through and observing things for a few minutes, but I've tried to capture that in a few slides. The physical environment here is the key, and there's a wide range of variability. I would say that there are small emergency departments that have just 6 beds and are a couple of hours from the next hospital. And there's other parts of the country where there are multiple major tertiary, what you guys would call a level 6 hospital within the same city. And so there's just a real broad spectrum of what it is when we say there's an emergency department. But this is a map on the top left of one of the emergency departments I recently worked at that had 69 different beds, a number of resuscitation bays, and was divided up into a pediatrics area, multiple adult areas, and then even had a behavioral health circumstance on a set of rooms that was tailored for those patients, and then kind of what we call low acuity patient throughput area where patients have smaller complaints like a simple laceration or a sprain where they can kind of be evaluated quickly and discharged relatively quickly. Every emergency department is run in a somewhat unique way, but many times there's commonality and similarities. You can see in that picture on the top right, room 305, that's a gurney where a patient has kind of oxygen suction monitor, computer for the electronic medical records, and the bed for the patient. There's plenty of room for multiple healthcare providers to be in the room and work. But there's often been, in the past 5 or so years, a move to the model that you can see in the bottom picture where patients are sitting in recliner chairs and have smaller areas. So for those patients that are less sick, that maybe have ankle pain or just simple cough, but have normal vital signs at triage, they may be more appropriate for these smaller square, footprints, where a provider could manage multiple patients in the same area that it would require if they were all in a single individual room. Generally, if a patient shows up to an emergency department in the United States, they would be met at the front desk by a triage nurse who would ask them what's going on, what brought them to the emergency department. And then based on kind of what they're complaining of and how they appear, they may be asked to wait and get their vital signs, or if they're sick enough, they may be taken straight back to a room for care. Oftentimes, patients are roomed or sent to the waiting area, and then once a room becomes available, sent back to a room. A nurse will frequently evaluate the patient first and document some of the basics of their chief complaint, their vital signs, maybe some salient points about their medical history or medications. And then once that's completed, the physician will evaluate the patient and perform a history and exam, and then determine what testing and treatments are needed. This is not, I presume, very foreign idea to many people, but kind of the workflow is then the physician would go back to their workstation and put in a slew of orders, and then the nurse would go back, draw labs, place an IV line if necessary, send the patient over for their radiology testing and things like that. The one difference is, as compared to what I've seen generally in Kenya, is we don't require any upfront payment. We don't require any cash guarantees or purchase of any services on the front end. There are registration staff that will look into your medical insurance, whether that's government insurance or private insurance, and try to help process some of that information. But by and large, the physicians in the United States in the emergency department try to make diagnostic and treatment decisions without real in-depth knowledge of the patient's financial or insurance status. And then some of those things may come around and need to be sorted out later. But by and large, we are treating our patients kind of with whichever way we see fit. Generally, it will take between 1 and 3 hours, depending upon the number of diagnostic and therapeutic tests that are ordered. A patient can expect, I can usually say when I'm examining them, here's what I plan to order, and here's how long I can expect until all that information is back. And at which time we can determine, do you need to be admitted, discharged, have a consult, or decide what's next. We have a variety of different diagnostic modalities available, as do you guys. But one thing that I think stands out is on the bottom right, the MRI machine. We have that in most hospital systems that have an emergency department will have an MRI. It may not be available 24 hours a day, and it's not common for patients to get an MRI study done while they're in the emergency department. But it's also, I think, much more common in North America than it may be in many other parts of the world, to consider that as a emergency department test that will then allow a patient to potentially go home if it's normal. And so it is something that we do use. You can see the formal ultrasound where patients are being sent to radiology, as well as frequently using portable x-ray at the bedside, particularly for critically ill patients who we don't think are safe enough to go to the radiology department, and the CT scan. It's interesting to note that in some large training centers, including one of our hospitals at Brown University, the CT scan is actually immediately in the emergency department, in the resuscitation bay. And so patients can actually get their CT scan literally just a few meters away from their gurney. And so even very unstable patients can get a scan done very quickly and somewhat more safely than if they had to travel down the hall and around the corner to the radiology department. Point of care ultrasound is a very important part of emergency medicine practice in the United States. Most emergency medicine physicians are using this, I would say, at least once in a shift, doing a variety of different scans for trauma patients, doing a fast exam, doing cardiac bedside echo, doing lung scans, renal ultrasound, looking at soft tissue abscess versus cellulitis, or things like that. The skills that a emergency medicine resident trainee are taught allow them to feel confident that they can do a number of bedside ultrasound studies and either rule in or rule out a variety of different diagnoses that might require formal ultrasound if they're abnormal, but oftentimes if normal can be reassuring and kind of the end of the investigation. The electronic medical record is a huge part of what we do in our work. It really is where we spend way too much of our time in practicing emergency medicine in the United States. We sit at our workstations that are computers. You can see the provider in the bottom right is using a dictaphone, and so most of us have incorporated this into our practice, where there is talk to text, where you can dictate your history, your physical, your decision making, so that your note is comprehensive and it's faster than sitting and typing. Generally, a provider could be an emergency medicine physician, maybe managing upwards of 15 or more patients at a time in various levels of their workup. And so using the computer to organize what testing is done, what testing is pending, what are we waiting on, how long has it been since the patient got their morphine? Do I need to go recheck on them? Those types of things are all really useful. Repeat vital signs get documented in the computer. And so it really does, it becomes this anchor where we spend more time on the computer than we would like, but it really does help facilitate the medical record being complete as well as accurate. Another point to make is a contrast I've noted in the United States as compared to a lot of other countries is the role of which tasks go to which individuals in the health system. And so in our emergency departments, it's the primary role of an emergency nurse to put in an IV line and to draw labs and send those off to the laboratory, whereas I haven't always seen that everywhere else. Sometimes that's the physician's role. Similarly, doing an ECG is often the role of a technician who is available in the emergency department at all hours of the day. And so anytime a patient has an ECG ordered, that individual will go do that within 1 or 2 minutes, and that ECG result can be done within 5 minutes for the doctor to interpret. We often have housekeeping staff who are available in the emergency department throughout the day and night, so that as soon as a patient is discharged, the housekeeping staff can clean a room, change the linens, and get that room turned over within a few minutes, so the next patient can get roomed and increase the efficiency of the emergency department care, so that the nurses and the doctors are able to focus on the tasks that are most valuable for them, while the housekeeping staff can focus on those other roles. There's a variety of different emergency medicine staffing models in the United States. I don't want to necessarily get into the weeds on all of these, but just to point out that we have a variety of different shift lengths depending upon the hospital you're working at. Sometimes people work 8-hour, 9-hour, 10-hour, 12-hour shifts, rarely 24 hours. Those tend to be in very rural hospitals where you're only seeing a few patients in a day, if any. There's a variety of different ways that emergency physicians are employed. They can be employed by the hospital directly, maybe by a company that covers several hospitals. And so you work for a company as opposed to the hospital, and you just get sent on a schedule to different hospitals. Sometimes emergency medicine physicians will come together and form their own independent group. There are some physicians that look for holes in the schedule and will work on a locum tenens type model where they frequently go work 4 or 5 days in one place and then the next week are in another hospital, and they move around a lot. Each of these models has a different amount of stress, a different amount of change and turnover, a different amount of financial compensation and benefits packages. So a lot of different times providers have to decide what are the geographic versus financial benefits of these different choices. This is a brief picture. Each of these blue dots is a hospital with an emergency department in the United States. You can see some clustering, and those are kind of around our biggest cities. But you can also see that particularly on the eastern or the right half of the country, there is a fair amount of spread. And as we get towards the west, that is kind of our more rural part of the country. And there's definitely, you can see through some of these states like Nevada and Utah, which are kind of on the far left, but not all the way to the ocean. You could go hours before you drive and reach the next hospital. So emergency medical services are definitely a part of the emergency care system in our country. And sometimes ambulances are used to transport patients between hospitals when they get referred to a higher level of care. They can be used to take a patient from home to the ED. And in some cases, we use the air ambulances, the helicopters, and fixed wing aircraft that you can see on the bottom right to transport patients from a rural hospital to a higher level center where they may need an emergent procedure. Adam will talk about some of those, but those would be situations where the patient has a life-threatening condition that we think, if we were able to get them to a higher level of care, it may improve the outcome and the quality of life. All right, so I'm going to hand it over to Adam so he can talk about some emergency care and some of the ways that we utilize healthcare in the US. Would you like me to stop sharing, Adam, or you want to just have me click?
Yeah, no, let me take over the screen sharing. That'll be better. Okay, is that coming through okay?
Yep, looks great.
Excellent, thanks. So thank you, everyone. Just to continue on, Austin gave a very nice overview of sort of the systems perspective and the structuring and kind of training and kind of history of emergency care in the United States. What we're going to move into now is a little bit of a change in focus and talk about utilization as well as kind of disease burdens and major causes of mortality, and talk through a couple of specific diseases and healthcare problems that we address in the United States in emergency care settings, to really look at the way that there's benefit for those and also burdens and potential problems, and then bring it back to kind of what that might mean for people in Kenya or in the earlier stages of developing emergency care systems. So emergency care utilization is fairly common in the US. If you look at the numbers, there's about 400 million people in the United States. So 1 in every 3 people on average about visits an emergency department for care every year. So if you have 3 people in your household, 1 of them will go to the emergency department on average if you live in the United States per year, which is a fairly substantial number. The number of visits that actually require hospitalization among those 130 million that come in is only about 16 million, right? So about 12%. Right? So many of the patients who come to the emergency centers are discharged, treated, and released, or sent back to their primary care providers to be treated more, or don't need any further treatment. So it's overall a low number that actually require admission and more care in the hospital. If we look beyond that, in the United States, it's even fewer that have critical illness and need admission, about 2 million. Right? So, about 1.8% of people who come to the emergency care centers in the US actually need critical care and admission to the hospital for that. Another about 2% are transferred to other facilities, and a lot of that is due to psychiatric needs and mental illness. On the last point on this slide, you'll see that there's a metric of patients who present and are seen within 15 minutes of arrival. And on average in the US, that's almost half. It's about 40% of people who come are seen by a physician or a healthcare provider within 15 minutes of arrival. That's a fairly impressive number, to be treated that quickly, but I have to say there's a great deal of variability in that. I've worked in emergency departments in the US where it takes 5 to 6 hours before a patient is seen, assuming that they're not critical and then, morbid bound, but I've also worked at ones where you're seen in 2 to 3 minutes. So there's a lot of variability among that. And as Austin was mentioning, the way that hospitals are set up is a lot dependent on, kind of the area that they're in, whether they're rural or urban, and what the staffing model is that exists there. So with so many people coming to the hospital, for emergency care services, upwards of 130 million per year in the United States, there is no limit on the different diagnoses and different problems that people present with. There's the saying that, emergency medicine is a kilometer wide and a meter deep. I don't really agree with that. I think we're more like a kilometer wide and a kilometer deep as a healthcare profession, in that we have to have both a broad understanding of different differential diagnoses, but we also have to have an understanding of how to take care of those, more so, particularly now that healthcare is overburdened, than just kind of emergently what to take care for them, but how to manage them longer term. As there's more taxation on the healthcare system, and we have to manage patients in the emergency departments for longer periods of time. Could be up to days or sometimes even a week, depending on how full the hospital is. We have to have a deeper understanding of the diseases and the treatments. So in the US, there are a lot of dangerous emergencies. Given the time we have for this kind of discussion and presentation, we obviously can't talk about everything. So we wanted to highlight a few key points and talk through a couple of diagnoses that we think are illustrative of kind of how care is provided in the US and some important things to consider. So this is data from the Centers for Disease Control and Prevention, which is our main health body in the United States. And it shows the top 10 causes of death. And this is data from 2018, with number 1 being heart disease. Followed by that is cancers and malignancies. Number 3 is unintentional injuries. Number 4 is respiratory diseases. Number 5 is cerebrovascular accidents. Number 6 is Alzheimer's. Number 7 is diabetes. Number 8, influenza and pneumonias. Number 9 is nephritis. And number 10 is suicide. You see there's a lot of diseases there that cause mortality in the US that have direct concern for the emergency care settings and ways that they can be addressed. Now, so what we're going to do is we're going to talk through a few of the emergent presentations for some of these diseases and kind of highlight some points around best practices that occur in the US and kind of consider, how good those practices are and what the repercussions of having the best practices mean for the providers and also the health system as a whole. And the ones we're going to focus in on are myocardial infarction, ischemic stroke, some aspects of trauma, and then one that wasn't on that list is opioid overdoses and opioid use disorder, which, as we'll discuss shortly, is really an important cause of morbidity and mortality in the United States that has been born out of some probably misuse and misprovision of medications by healthcare providers over the last couple of decades. One quick point, obviously COVID-19 is kind of the predominant disease in the world as we speak today. We don't want to gloss over this in any way, shape, or form. However, we realize there's been a lot of focus on COVID-19 in many teaching settings. And it's, although impacting emergency care, we just wanted to, ensure that we're providing important information that kind of speaks to emergency care at large and not just in the setting of the pandemic. So the reason we're not integrating it into this discussion, this presentation specifically is, I think everyone's had a lot of COVID-19 over the last year. And, we kind of wanted to focus on just the larger idea of emergency care and some specific examples around that. So we said the number 1 cause of death in the United States is heart disease. And the most substantial form of heart disease and emergent form of heart disease is myocardial infarction. And this is a diagnosis and a pathology that's very, very important in emergency care. It's a disease that has an immediately identifiable cause and an immediately applicable treatment. Right? So it's something that is the kind of the prototypical example of what emergency care can do and how it can be impactful in societies. And the ST elevation myocardial infarction, this is the way that the diagnosis is made and, the most aggressive form of heart disease, and acute and aggressive form of heart disease that we deal with. So it's something that all emergency care providers in the United States have to be adept at understanding and identifying and also caring for. And our treatments are really dictated for many things, but in ST elevation myocardial infarction specifically from our societies and guidelines. There's guidelines that exist within our house of emergency medicine and those that exist from places external to our house. And the American Heart Association is sort of the primary body that provides us guidance and treatment approaches for STEMI, ST elevation myocardial infarction, external to emergency medicine. And then the American College of Emergency Physicians, which is sort of our primary governing body, also provides information on how we should approach treatment of all diseases, but specifically we'll focus in on ST elevation myocardial infarction. So the key consideration in the United States around STEMI cases is time. So this is really the first disease process in kind of contemporary medical history where we identified that time is a function of mortality, right? So the longer time that passes after a myocardial infarction has begun, the increase in mortality will occur. And there's a graph, and this data is from the 1980s that kind of shows the mortality increase over time from the onset of symptoms. And so because this is a time-sensitive diagnosis, the metrics of time are kind of monitored as care is provided and really dictate what needs to be done and how quickly it needs to be done. And the interventions for myocardial infarction in the United States are primarily twofold, from actually reopening the vessel and reperfusing the injured muscle in the heart. And these are what's called PCI, or percutaneous interventions for angiography. And that's where an interventional cardiologist, not an emergency care provider, accesses the vessels of the body, goes up to the heart and opens the coronary arteries, and generally puts in what's called a stent, which is a tube to open up and keep the vessel open. This is the preferred modality and really has the best evidence in terms of being impactful and reducing morbidity and mortality in patients who have STEMIs. Below that, you'll see an image of what's called recombinant TPA, or tissue plasminogen activator. And this is what's called a clot busting drug, and it's used to open up the vessels from a medical approach rather than an anatomical approach with an intervention. And this is what was used before there was PCI, and is still used in a lot of places around the world, and is sometimes used in the United States. But the primary consideration, the primary preference is to use percutaneous interventions by a specialist. And because time is so important, the way that it is dictated and the way that it's approached by emergency care providers in the US is all centered around how quickly things can be achieved. And there are very strict guidelines and requirements that when we identify an ST elevation myocardial infarction, that patient is treated rapidly. And specifically, the goal is to have what's called the door to balloon time, or the DTB, be less than 90 minutes. So as soon as the patient reaches the hospital, they need to be in the catheterization labs with the cardiologist on hand, and the balloon going up into the artery within 90 minutes. As you can imagine, this is a lot of moving parts to take care of and to actually make happen, meaning that we have to diagnose the patient, we have to mobilize the cardiologist and the heart team to be able to access the procedure and be able to perform the intervention. This has not only a lot of moving parts, but also has a lot of money that has to be put into it to make it happen, because you have to have a heart specialist on call 24 hours a day, as well as their entire team to help support them and do the procedure, including the cardiac nurses and other support personnel. As Austin had mentioned, the distribution of hospitals in the United States is not uniform. And beyond that, the presence of hospitals that have the ability to do PCI for STEMI is also not uniform. There are about 2,200 hospitals, and they're shown on this map, that have PCI capabilities in the United States. As you can see, there are a lot of states that don't have many, and some that don't actually have more than 3. So it makes it very difficult for the 90-minute door to balloon time to be achieved if you're 4 hours from a hospital that has the capability of doing so. So in that cases, the US uses what's called a spoke and hub model. And this is used in Europe and a few other high-income countries as well. And basically the idea is that there's the central hub or the facility that has the service, the specialized service, in this case, percutaneous intervention for STEMI. Right? And then the adjacent hospitals are the spokes in that system, right? And they can triage the patients and move them to the hub hospital as needed. Right? This helps with time to diagnosis, as well as ensuring that the specialists are aware that there is a patient who needs specialized care coming in, and increases the uniformity in the distribution of the care services across the country. We said the goal is 90 minutes from door to balloon time, and that door to balloon time starts when they reach the first hospital, so the spoke, not just the hub in the middle. And so you can imagine it can be very difficult to get the patient to the balloon within 90 minutes. So there's secondary guideline for that in our setting is if you're not able to get the patient to the hub hospital where they can have the percutaneous intervention within 120 minutes, so within 2 hours, then you will first treat them with the TPA, the tissue plasminogen activator, to hopefully break up the clot, and then they're subsequently moved to the hub hospital. Right? This is sort of a less than ideal situation, but it addresses the limitations of the system in relation to the geographic distribution of the facilities, and what the access can be for patients and populations in more rural settings. So the PCI for STEMI model has been very impactful in the US and in a lot of other places. It's certainly reduced mortality. It's resulted in better cardiac outcomes and people with less morbidity and better exercise tolerance. About 10 years ago, we started to think, well, cardiac arrest is most commonly caused by heart disease. We know that. So what if we just did PCI for everyone who came in with cardiac arrest instead, even if they did not have an ST elevation myocardial infarction on their EKG after they were revived. This is a concept of somewhat indication creep, right? So indication creep is the idea where you start doing things outside of the population that it was studied in. So this started to be done actually in a few places, and then everyone kind of said, wait, we need to think about this a little bit more and do some actual formal research. So thankfully, about 7 years ago, they started the studies on this, and they were rolled out. And the largest one was called the COACT trial, and this was actually done in a couple of settings in Europe. And basically, what they were doing was taking those patients who had cardiac arrest but did not have STEMIs on their post-arrest EKGs and taking them for early catheterization. The outcomes were that it made no difference whether you took them for immediate or delayed angiography and looked at their coronary arteries. There was another study ongoing in the United States at that time called the ACCESS trial that we were actually a study site for and we're enrolling patients for. And that was actually stopped after these results came out because it was pretty clear that there was going to be no impact with this strategy and approach, right? So although PCI absolutely has a role in the treatment of STEMIs, we did not need to extend that to all patients who had cardiac arrest, even though it's most likely the cardiac arrest was occurred due to secondary to cardiac disease. So that's a brief foray into aspects of STEMI and care in the United States. It's very much driven by time aspects and the utilization of large systems that have multi-specialty coordination, right? And even multi-institutional coordination from the spoke and hub models. We're going to shift a little bit now and talk about another major process in emergency care. That's trauma and unintentional injury, which is the third leading cause of death in the United States overall. And it's actually the first leading cause of death for people between the ages of 1 and 44. So a large amount of people in the United States population, and globally as well, the same numbers hold true. So trauma is a complex science, and in emergency care, it's something that we take care of very frequently. There's a great deal to it, more than we can cover, obviously, in a short session such as we're having right now. But in the US, it's primarily governed by what's called the Advanced Trauma Life Support Program. And this is an educational training that's put out by the American College of Surgeons, and it's used not only in the U.S. but in a lot of other parts around the world. You know, and even in sub-Saharan Africa, it's been used, and it provides a sort of codified and formal set of guidelines on how trauma should be approached and taken care of. You know, in all honesty, it has a lot of shortcomings that most well-trained emergency care providers can probably do a better job on. But as a whole, and a population level, it provides a common language for people who don't necessarily take care of trauma on a regular basis to be able to interact with each other and provide care that's sufficient to prevent undue mortality. It was most recently updated in 2018, and this was the 10th edition. And just as a consideration over the years, the Advanced Trauma Life Support Program has been somewhat criticized for being late adopters and not incorporating the most up-to-date science and data in their recommendations. You know, so this is one of the reasons that emergency care providers sometimes feel less comfortable with using the ATLS or Advanced Trauma Life Support Program without any revisions in how it's applied. And one example of that is volume resuscitation. So, you know, in injury, the most common actual cause of death is exsanguination or bleeding to death. So for many, many years, the Advanced Trauma Life Support guidelines would basically put forth that, well, initially it was provision of either colloid or crystalloid, so volume expansion with fluids, not blood. And that over the last couple of iterations was specifically normal saline or Ringer's lactate, a crystalloid solution. You know, prior to the last couple of iterations, it was at least 2 liters. That's been brought under question by a lot of research. And if you just think about it rationally, you know, people don't bleed the saline part of their blood, they bleed actual blood. So that needs to be what is replaced. Right? And the scientific kind of understanding of that is, you know, when you provide volume resuscitation with fluids instead of blood products, you're basically worsening the propensity or the likelihood that someone's going to continue to bleed, right? Because you're diluting their coagulation cascade, you're making them colder, and normal saline, which is the most common crystalloid used in the United States, is actually an acidotic fluid, which also worsens bleeding. So thankfully, in the last iteration of the ATLS manual, training manual, they finally acknowledged that they needed to move away from the use of crystalloids, to everyone's applause, you know, and move towards early blood products. They didn't go as far as to say no crystalloid fluids at all, although most people who practice emergency care and trauma resuscitations regularly do feel that no IV fluids is the best approach. However, blood's expensive, and blood products themselves are also expensive and a relatively rare commodity. You know, to have O negative blood or O positive blood, you know, are hard things to come up with, you know. So packed red blood cells, cryoprecipitate, fibrinogen, fresh frozen plasma, and platelets are all the things that we get out of whole blood, and things that are repleted when you're providing volume resuscitation in a trauma patient. You know, and the different parts actually have different expenses and different logistical aspects in terms of harvesting, storage, and delivery. So one of the questions that existed in trauma science and trauma care over the last 5 to 10 years was, what was the ratio that should be transfused for volume resuscitation in a critical trauma patient? With the idea of should the ratio be 1 to 1 to 1, so 1 unit of packed red blood cells to 1 unit of plasma and 1 unit of platelets, or 1 to 1 to 2, so 2 units of packed red blood cells for every 1 unit of plasma and every 1 unit of platelets. You know, this question may seem a little bit arbitrary, but it actually has a lot of implications in terms of, you know, the logistics of blood supply and product delivery, and also kind of given the burden of trauma in the world, you know, how much product will be utilized and in what ratios. So the proper trial was performed, and it was the Pragmatic randomized optimal platelet and plasma ratios trial. And what it basically found was that there wasn't much difference. There was no difference in mortality. They did say that a 1-to-1 transfusion versus a 1-to-1-to-2 had less bleeding in the near term and death secondary to that bleeding. So that was really what was settled upon and adopted by the ATLS program. So volume resuscitation really has moved away from crystalloids. And now the ATLS guidelines do say it's okay to give 1 liter of crystalloid, but many of us in emergency care in the US feel that the science really doesn't support that. And the use of blood products early is really the most appropriate step. The caveat to that, of course, is that blood is expensive relative to crystalloids, so it should only be used in patients that truly need it. As well, given the proper trial, it's recommended that transfusion occur in a 1-to-1-to-1 ratio for patients that will require large volumes of transfusion. So as you can see, trauma care, which is often viewed as relatively simple, has a lot of nuance to it. It's been driven by science more so over the last couple of decades, and is really kind of a joint organization between trauma surgery and emergency care, and has a lot of thought process around how it's approached and what's performed. We're going to move on to another topic. This is ischemic stroke. So ischemic stroke is the fifth leading, stroke in general is the 5th leading cause of death in the United States. Ischemic strokes account for about 80% of all strokes that are seen in high-income countries. And they do cause mortality, but the larger burden is actually morbidity as a result of ischemic strokes. And that morbidity often has a high societal cost in terms of dollars spent, but as well the disability and quality adjusted life years that are suffered by patients who have an ischemic stroke. Much like myocardial infarction, ischemic stroke is a pathology in the United States that has a lot of clinical guidance from guideline committees. Primarily, the American Heart Association is the body that dictates kind of how we care for these patients. Our own body, the American College of Emergency Physicians, also provides information around this and how we approach them. But the Heart Association is really the ones that kind of dictate the overall approach and treatments in the United States. And really there are 2 approaches and 2 treatments that are key and not without controversy in our practice settings for emergency care in the United States. And these are recombinant tissue plasminogen activator, or TPA, which is a medical therapy for ischemic stroke, similar to that's used in myocardial infarction. And then endovascular retrieval of clots, which is a relatively newer treatment algorithm, but something that also has had a fair amount of data over the last couple of years. So TPA for ischemic stroke has been studied fairly substantially. This is a table I borrowed from an online blog, actually, that reviewed the 13 trials that have been performed on tissue plasminogen activator for ischemic stroke. As you can see, the results are fairly mixed. The are really only 2 positive studies that have shown benefit for disability. TPA has never been shown to reduce mortality or death related to ischemic stroke, but there has been some signals, at least in 2 studies, that it reduces the amount of disability that a patient will have at the 3-month time point. Related to that, there have been a number of studies that have shown no benefit, or some that found that it increased death or had no positive impacts. This is probably the most debated topic in emergency care in the United States, is the utilization of this drug and whether it has a place in ischemic stroke. I don't know that anyone truly knows the answer to that. Personally, I believe it does have a place in selected patients and probably does have some benefit for specific patients who have certain types of strokes. However, it's utilized very rapidly in the United States for in many cases where it's probably not indicated. And it's 100% endorsed by all governing bodies outside of emergency medicine and specifically from the neurology space, from the American Heart Association and vascular diseases. So it's, although not something that's, I believe, supported by the best evidence, it is this, for all intent and purposes, the standard of practice in the United States, and is given for ischemic strokes among patients that meet criteria for it. I mean, if you look at the American Heart Association, this is how they represent the data for TPA and how it impacts ischemic stroke. Basically, that it reduces disability by about 10%. And they really don't pay much attention to the downsides of the medication from the other studies. This is unfortunate, and I think it's probably a disservice to patients, but it's the situation that we practice in within the United States. You know, it's important to note that the risks of bleeding inside the brain after you're given this medication is about 4%. So, you know, you could argue that the 10% benefit for disability is greater than the 4% risk for hemorrhage, intracranial hemorrhage. However, those risks of hemorrhage go up as patients get older and with larger infarct sizes. So it can be up to 15 or 20% actually. It's also not a cheap medication. Each vial costs $7,000 US. So, and that's a relatively conservative estimate. Some say it costs up to $10,000 depending on the healthcare system. So this is a medication that has potential risks and a high price tag and is utilized very frequently. Much like myocardial infarction, the ischemic strokes are monitored because time is thought to be brain in these cases, although I'm not 100% certain that that's true from the tissue plasminogen activator perspective. Due to that, there's what's called the door to needle time. Remember, we talked about the door to balloon time for STEMI. This is the door to needle time for ischemic stroke. And basically, this is the idea that you have 60 minutes from the time the patient arrives in the emergency room to get TPA into their body. All right, so this requires making the diagnosis, assessing the patient, ensuring that they're stable, obtaining a brain imaging, right? Because you have to make sure that they're not having a intracranial hemorrhage, and they are having ischemic stroke, you know, and getting that interpreted and read, getting the medication mixed, and provided to the patient all within 60 minutes. This is a fairly complex thing to do, and in almost all hospital systems now in the United States, this is performed via what's called a code stroke or a stroke code, such that, you know, when the patient arrives and there's concern for a stroke, this system is activated and it mobilizes not only nursing, but the physician providers and whomever else needs to be on call to make this happen. You know, in some cases, if there's a neurology service within the hospital, they'll also come to the emergency department to assist with the code stroke. But, you know, it's not always the case that you have neurology, especially in smaller hospital settings, and you may have to make the decisions and do the care on your own. As I said, time is the primary driver of how this care is reviewed and understood. This is an example of a patient I took care of about a week ago who came in with a code stroke. And I get these reports, and everyone in our hospital system receives these reports on their stroke patients. Right? So if I do a good job and I get the TPA ordered and in within 60 minutes, I get a happy face in my email. If I don't, then I get a slap on the hand and I get yelled at why I didn't get it in. Right? So as you can see, it's very documented and regimented. They mark down the time of when the patient arrived, when the stroke code was activated, when the imaging was performed, when the TPA was ordered, and when the TPA was given. In this case, we provided the TPA within 34 minutes of arrival, so I got a nice email instead of a nasty email. The downside of this is a couple-fold. One, it pushes providers to rush in their evaluations and potentially provide TPA when it may not be the best thing for the patient. All right, we know there are a lot of mimics to ischemic strokes, such as, complex migraines, seizures, conversion disorders, and the drug is not only expensive, but it also is with risks in terms of hemorrhage. So we need to be careful in who it's provided to. And in many settings, it's kind of just the default option is to give this medication. This is one of the downsides and the burdens to practicing in the United States for certain, is that we're under time pressure to reach these metrics. And as such, we're providing medications that may put the patient at risk. And that seems to be deemed acceptable from our medical societies and our standards of care, even though I think I speak for myself and others that I know don't agree with that, and think we need to be more aware and prescriptive in how we're approaching these patients. So it's one of the problems with our system. The newer kind of approach to treating ischemic stroke, which has kind of evolved for the last 7 to 10 years, is endovascular therapy. This is similar to PCI for STEMI, where the interventionalist goes in with a small catheter and actually grabs the clot and removes it. It's a very invasive, relatively speaking, because you're putting a tube into the brain, into the vessels of the brain, but it seems to have positive benefits. There have been a number of trials for this, and unlike TPA, there seems to be sort of a consistent outcome of benefit. There hasn't been a lot of downside observed. There are complications, obviously, with the procedure itself, but nothing too substantial in terms of harms. Excuse me. And this has really been pushed as sort of the next stage in ischemic stroke care. And it has, as per the American Heart Association, about a 20% improvement in outcomes in terms of disability for patients that qualify for treatment with this approach. I would say those numbers are probably a little bit overestimated. And if you read other review papers on the topic, it's probably more in the range of about a 10% improvement. So still substantial. A number needed to treat of 10 to improve outcomes among one patient is a worthwhile healthcare intervention. But it's not as impactful as some people put it forth as. This, similar to the use of tissue plasminogen activator in ischemic stroke, is also very prescripted in terms of time. And, the metrics are evaluated on this similarly, and there's a push to make it happen as fast as possible. I would say, as compared to TPA, this treatment approach is even further removed from the input of the emergency care physicians and the emergency care practitioners in the United States. Granted, we are the frontline providers who will assess the patient and make the decision if a stroke is likely. But once that occurs, the decision to perform endovascular interventions and angiography within the brain is really at the discretion of the interventionalists. And this could either be a neurologist or a neuroradiologist who's going to do the procedure. These centers are very specialized, even more so than those that are capable of doing PCI for STEMI. There are increasing in numbers in the United States, but they're rare with, 1 to 2, up to 5 at the most per state in the United States. So these also use a similar spoken hub model, with screening and kind of on-call physicians who can do the procedure in their teams, only at very specialized centers. So I've worked at about 8 hospitals in my life, and I've only ever worked at one hospital that had this procedure on call and was a hub center for it. So the patients who get these are not very common, right? So you can only, as you can imagine, you can't get to the very small vessels with these devices. You can only get to very, very, very large vessels. So it only works for ischemic strokes in the internal carotid, the anterior cerebral artery, or the middle cerebral artery. And it has to be within 24 hours and with imaging that shows that, you're likely to have some benefit if you go and take the clot out. So if you look at the numbers, it only happens at about 1 in every 750 strokes, right? So that's not much. That's basically a needle in a haystack, right? Or really it's more like a needle in a stack of needles, right? Because you're looking for a specific type of stroke amongst a bunch of other strokes. You might say that's okay. You know, it seems like it's an impactful procedure and it probably has some benefit. The problem with that perspective is that unlike just your normal ischemic stroke where you only need perhaps a non-contrast head CT to make sure there's no bleeding, now you need an angiography exam of the head and neck, which is okay, it's obtainable, but it's expensive. So on average, it's about $10,000 US for each one of these studies to be run, interpreted, and reported on. You know, if you're doing that on 750 patients to find one, you know, you're spending a lot of money to find one disease. Is it worth it? It might be. It's a societal discussion and a societal decision that needs to be made. You know, in the US, the cost effectiveness of this approach, they say it costs about $5,000 US to obtain one increased quality adjusted life year per person. In the US, that's something that's considered a worthwhile expenditure. So we do this. But, you know, this is not something that I think is applicable in all settings. I think it depends on what your healthcare priorities are and where your health systems think that the money should be spent the most effectively among patients. You know, this is another example of indication creep in emergency care. You know, now every single patient who comes in with any concern for a stroke symptom in most of the hospitals that Austin and I work in will have a CTA of the head and neck. Very, very rarely will that change emergent management. In fact, it almost never does, right? But it does cost a lot of money. It provides undue radiation to the patient, right? And just basically slows down care to other providers and other patients within the healthcare system. Again, this is kind of the perspective of the benefits and the burdens of having systems that are, you know, evolved in a way that they value a lot of advanced imaging and advanced testing for specialized care. Is it the right thing to do? As I said, I'm not certain. I think it depends on the setting you're functioning in, you know, and what your overall healthcare resources and availabilities are. Now we're moving on time, so I'm just going to touch on one more brief topic because it's something that's become very important in the United States over the last number of years, and that's opioid use disorder. We have had what's called the opioid epidemic and have increasing deaths due to opioids in the United States. Within 2019, having 70,000 deaths from overdoses. That's about 1 in every 5,000 people in the US population dying from an overdose death. And in 2017, people in the United States were more likely to die from overdose than they were from motor vehicle injury. This is largely driven not necessarily by injection drug use and heroin per se, but more from opiates from pills and prescription medications, as well as street opiates and pills. Now, the importance of this is those who present with an overdose to the emergency department in the US, a recent study found that 1 in 20 of those people will die within the next year. And of those that die within that 1 year time period, 50% will be due to a repeat overdose event. This has led to the emergency departments becoming sort of frontline providers for outpatient overdose treatment. You know, obviously when a patient presents with an overdose, we have naloxone or Narcan, which is a reversal agent for opiates that's very effective. And as long as the patient has not been in respiratory arrest or distress for too long, you generally will get a good outcome from this. You know, we've developed sort of protocols where, you know, after rapid observation periods, you know, patients can be discharged with take-home Narcan kits, which are sort of nasal sprays that can be used if another overdose event occurs. And they provide actual take-home kits that people leave the emergency department with. You know, these kits are immensely cost-effective. The kit costs about $70 US on average. You know, so $70 to save one life compared to $5,000 to increase one quality adjusted life year is a substantial investment from society from the emergency care settings. The other sort of key aspect of opiate use disorder in emergency departments is initiation of medical assisted therapy. So this is basically outpatient treatment for substance use with opiates. The importance of this approach is that, patients generally don't interface well with health systems when they have a misuse disorder, particularly with opiates, and especially for intravenous drug users. And sometimes the emergency departments, particularly in the US, are the only place that they'll be evaluated and treated. So it's a really key opportunity to begin initiation of treatment for medication-assisted therapy, and buprenorphine is kind of the medication we use for that. It also has been studied that when we do this in the ED, we potentially can get them into treatment more reticently and keep them in treatment, at least near the short term. The long-term impacts of this are still unclear, but from my perspective, it's such a problem in our healthcare setting in our country overall, and it's a very low energy and high impact opportunity that we can take up in the emergency department that really probably has as much far-reaching effect of anything else that we do in our current state. So it's something that's very, very impactful in terms of the morbidity and mortality that it causes, and that we can address without too much heartache and too much resource expenditure from our side. So that was a bit of a foray into kind of some different diagnoses that we deal with and aspects of them in emergency care settings in the United States. Just to kind of wrap up a little bit before we move into questions, we can say that in the US and in many high-income countries, emergency care is pretty expansive. It covers a lot of disease states and really focuses on care networks that can be provided that can address high-impact diseases such as myocardial infarction, ischemic stroke. We know that, in the US specifically, there's a lot of more rural areas where these care models kind of break down, and, other sort of nexus models have to be used to address the healthcare needs there. We also kind of have noted that there is a lot of structured care that's dictated and to emergency care providers, specifically around, ischemic stroke was the example we discussed, and that comes not only from external bodies, but also internally from our own boards, our own College of Emergency Care Physicians. And what I hope we've kind of illustrated is that there are benefits to that, but there are also burdens and potentially downfalls in terms of utilization of resources and medications that may or may not be clinically indicated all the time. The sort of take home from this for those of you in Kenya, and honestly in a lot of sub-Saharan Africa currently, is that as you are in your more early stages of development of emergency medicine as a specialty, this is your time to shape how emergency care will be delivered, not only now, but moving forward, and really to help those that make the policy in your setting kind of develop ways that are going to be most cost-effective, most important and impactful to the populations that you care for, and really just provide the best emergency care systems that you can, and that makes sense for the populations that you'll be working with. So I hope that was helpful and gave you some insight into kind of how we approach emergency care. I'm going to pause now because I've been talking long enough, and maybe we can take some questions if they're out there.
Yeah, Adam, thank you. That was a very, very educative session from both you and Austin. You've covered a lot, actually. We've learned a lot from the both of you, and thank you very much for that. Let me just ask a few questions. There's a question here Austin has said he'd like to answer. Sam has read my mind. As you were doing the presentation, the confusion between emergency care and critical care, there's a lot of confusion here in Kenya. People, because we don't have emergency medicine, people always confuse a critical care specialist with an emergency medicine. And I don't know about you, but I like saying, when you say stable and critical, that's critical care. And when you say unstable and critical, that's emergency. But maybe Austin can, yeah.
Yeah, the way I think about it, and it may not be the only way to think about it, but We are critical care doctors. We can provide critical care that they would provide in the ICU. Part of our residency training is to spend upwards of 5 or 6 months in a variety of different ICUs, the pediatric ICU, the trauma ICU, the surgical ICU, the medical ICU. So we get a lot of exposure and education on critical care medicine. There's, critically ill patients that show up to the emergency department will have the need for ICU level of care, and almost any emergency physician can provide that level of care for some amount of time, usually a couple of hours to start the treatment, to maybe intubate the patient, to get some diagnostic radiographic studies, those types of things going, and then get them admitted to the ICU. There is, the delineation to me is a physical, the emergency department or the ICU, but we in the emergency department can provide that critical care. It's just a longer time horizon of the patient can only be in the ED for a few hours and then needs to go to the ICU for ongoing care. The caveat I'll add to that is that, like I mentioned in those subspecialty fellowships, there are people that are interested in doing emergency medicine and going on to do critical care. And so some of those people will go practice. They may practice in the emergency department a few days a week and then do a week where they work in the ICU and then go back to the emergency department the next week. So there's people that use that model. And there's a recent innovation in the United States to develop what are called like mini ICUs, where you admit someone from the main emergency department to a unit that's nested within the emergency ward, where a patient can get something like 12 to 24 hours of ICU care, with the hope that then they can either go to the floor, or if they're not getting better, get admitted to the formal ICU. I think the best example of this is probably patients with diabetic ketoacidosis, or DKA, where if they get resuscitated, they need an ICU because of they need an insulin infusion and fluid management and close frequent lab checks of their potassium. So they have a need for frequent care. So they need an ICU, but they may only need it for 12 or 24 hours. If the numbers can get fixed, then they can go get admitted to the floor as opposed to having to use an ICU bed. So there's kind of an evolving thinking of what is critical care medicine and where does it physically take place. But Adam and I do not work in the ICU day to day, but we do ICU level medicine most days. I hope that answers that question.
Yes, it does. So we have another question. Somebody is asking about atropine in opioid versus organophosphate poisoning.
Mm-hmm.
Okay, I'm not familiar with using atropine in opioid poisoning or overdose rather, but somebody's asking, do we use atropine in opioid? I don't know. Maybe you can clarify on that.
No, we don't use atropine in overdoses related to opioids. It's kind of a different mechanism. Very important in organophosphate poisoning, obviously, but the opiate receptors aren't acted on by the atropine. So naloxone, or Narcan, as it's called in the United States, is kind of really the primary treatment medication, and is immensely effective, very, very effective. Obviously, these can be very trying cases. And as I said, it's really been kind of the focus prior to COVID-19. It was really the kind of the main focus in our emergency care settings to help treat these patients more aggressively.
Yeah, thank you, Adam. I think there was somebody who asked something about the STEMI. Here in Kenya, we mostly have morphine and oxygen and aspirin. I've seen often you have commented, but kindly just make a brief comment on oxygen, because I know the guidelines were revised and not a lot of people have that information, I think.
Yeah. So oxygen, is no longer one of the standard medications unless the patient is hypoxic. So less than, I believe it's 92 or 94%. I don't know off the top of my head what the number is. But you don't want to just reflexively provide oxygen to patients with STEMIs. And really, this has kind of been the movement in all critical illnesses, because too much oxygen, like everything else, is a bad thing. Right? There's a saying that everything's a poison. The only difference is how much of it you take. So, the provision of oxygen for STEMI is only indicated in patients with hypoxia. I know we give it routinely in a lot of places, but that should not be the case anymore. It hasn't been found to increase mortality, but it has been correlated with increased size of infarct on the tissues in perfusion scans after STEMIs. Likewise, we do the same thing for ischemic strokes and basically anyone with critical illness. We just want to maintain normoxia and not hyperoxia, because that can be more dangerous because it creates more free radicals.
Yeah, thank you.
Should not be given anymore. That's also been taken out of the guidelines.
Morphine, yeah, people don't give it anymore.
Yeah.
Okay, I didn't know that. Definitely need to review
How
my
many PCI
SCLS.
centers are there in Kenya?
Honestly, in the public sector, KNH, but unfortunately, we don't pick MIs as much as we are supposed to, or probably they come in too late. Coast General has just had a new cath lab setup. I don't know if they are operational. I do not know of any other public facility, but for the private facilities, I'm sure there are many. Aga Khan being amongst them, Nairobi Hospital, Nairobi West, if I'm not wrong, Aga Khan, Mombasa. So for the private hospitals, they're a bit more proactive when it comes to the PCI. But in the public, we are, I think also because our clientele do not have a lot of diabetes and what have you, we don't have a lot of STEMI in the people who come to public hospital. Maybe that's one of the reasons. I'm not really sure.
It could be.
Yeah,
might not be looking
because
for
of we're not looking for it. But anyway, we've been actually a quick question. How common is it for 29-year-olds to have STEMI? Because there's that variance of people who have the appearance of an ST elevation on the V lids. So how common would it be for you to quickly say that this is a STEMI and it's somebody who's 29, no risk factors, no what have you? I don't know. Yeah.
So younger populations, less common. No pre-existing comorbidities, less common, of course. There's the differentiation between early repolarization patterns and STEMI in the anterior leads. So V2, V3, most commonly is a differentiation that can be difficult at times to do. So it's really a lot driven by kind of the clinical presentation and the morphology of the elevations. There's a couple of decision rules that can be used to kind of differentiate what's called a subtle STEMI, and there's actually a phone app for it for that specific presentation in the anterior leads. So that could be helpful, but overall it's not common, and that's actually something that people struggle with, is differentiating early repole versus elevation myocardial infarction.
And it's a lot, and it seems to be a lot more common in the young age group with the lean people with lean bodies.
Younger males with thin chest walls, so people without a lot of chest wall musculature, is that you'll see that in. It's just because the forces of the heart are so close to the actual EKG leads.
Yeah.
One thing I would add as well, that generally a patient with an actual myocardial infarction will have, whether it's chest pain or they may have an equivalent like shortness of breath, or something else should be going on. They shouldn't, if they come in, maybe it's, epigastric pain or something that would make you think this could be the heart. But if they come in with my right toe hurts and you happen to get an ECG that has that abnormality, I would not jump to this is a myocardial infarction.
Yeah. Thank you. Just a quick one. How have you guys embraced artificial intelligence? Because I've been in enough forums whereby a lot of people are discussing artificial intelligence in terms of reading X-rays or CT scans or, all those things has it been embraced? Because it seems to be from the Japanese a lot more. So I don't know if that
US,
practice
not so
is,
much.
yeah.
No, I mean, it's mostly in the kind of the research phases,
Mm.
and not so much in emergency care, but in kind of like evaluation of radiographic images, specifically for cancer screening and mammography, CT scans for lung cancer screening. There's been a lot of kind of artificial intelligence around that. Machine learning algorithms for early prediction models for decompensation in the ICU is also something that's been done, where they kind of integrate, many thousands of data points all at once from vital signs and laboratory abnormalities to kind of see if they can predict the course and the trajectory of the patients over time. So it's mostly experimental and research based at this point, not so much in clinical practice here, that we use on a regular basis.
Okay.
I think there's a place for it, but we have to be leery of completely replacing human understanding and human interaction and human decision making.
Yeah, I can see Dr. Masasabi has informed me about the cath lab in KU. I don't know if it's ready yet. Dr. Hari, maybe I will upgrade you so that you can make that comment. Somebody has asked regarding the costing. All I can say is I'm not aware about the costing everywhere in Kenya, but of course, Relta and Alta don't cost $7,000 in Kenya.
Mhm.
We normally get a subsidized rate. I believe in our setting, it's about 40,000, 50,000. It's really subsidized for us. But even that subsidized rate is quite expensive. $500 is a lot in Kenya. And not a lot of people have that. Yes. Adam, is there any other particular question that probably you have answered, you or Austin, that you'd probably want the crowd to know about?
Not that I can think of off the top of my head. I would say that, as kind of we brought home at the end that, emergency care is in its early stages in Kenya, and this is really your guys' time to shape how it will move forward. So please learn from what's been done well and what's been done poorly in other sessions and other places from around the world, and move forward with that in a way that's going to be beneficial in your setting in Kenya. And, hopefully, we can continue to have these collaborative kind of educational sessions, and we can learn from you guys as well as we move forward.
Yeah, thank you. Dr. Masasabi, maybe you'd like to make the comment?
Yeah, thanks, Amina. I think that was a very insightful presentation from Dr. Adam and Austin Lee. As policy implementers, I think it has given us a heads up as we try to implement the EMS policy. So it's not an easy task, but we are thinking also of that spoke and hub model in our model for implementation of UHC. So hopefully we'll carry that model and start with the existing tertiary and link them to the level 4s and 5s. But just for information is that we had a cath lab constructed about 3 years ago at KUTRH, but the floor, when I looked at the initial pictures that were being shown by Dr. Adam in the floor was found to be a bit defective. It was far from some of the critical care units. Therefore, it's being relocated with the input of some experts from Aga Khan University and Kenyatta Hospital. We had a few consultants from Kenyatta Hospital coming to assist us. We have now a cardiologist on board. The challenge, has been actually getting interventional physicians and getting medical officers to be able to have a high index of suspicion. So we are hoping that as we participate in most of these webinars, and as some of our A&E departments, like at least KUTRH now, we have 2 well-trained emergency physicians who are now offering a lot of CMEs in the hospital. The index of actually now diagnosing MI has increased, but for intervention, sometimes we rely on KNH. We diagnose them, send them in good time, and you have been very supportive. So I think collaboration, when you look at the expenses that have been highlighted in the presentation is not a very little money, but I think with the commitment and a sequential planned approach, we should be able to get there. Otherwise, thank you for that presentation. And Amina, thank you for organizing such important presentations. Thank you and over.
Thank you, Dr. Haji. So, yes, Adam and Austin, thank you very much for the presentation today. You have informed us a lot about emergency care and where we have to go. I love the way you say that it's not a developed country, it's more of a high-income country. That note has been taken. Do you have any parting comments?
No, just thank you for giving us the opportunity to, collaborate with you and provide some insights from our side. We can provide our emails if there's any questions, and please, I think you have both of ours, please send them out as needed. And we're happy to share a copy of the presentation slides if anyone would like them.
Yeah, thank you very much. Thank you, Adam. Asante sana, Adam. I know Adam speaks Swahili. Yes, Austin?
Tunashukuru sana.
Adam speaks Swahili and Austin speaks very, very limited Swahili, so I won't even try. But I just want to, echo the thanks for giving us the time and the opportunity to talk about this, but to realize that, like Adam was saying, that you guys have the benefit of learning from mistakes that have been made in much of the rest of the world, and learn and grow your system in the way that works best for Kenya. And so hopefully there's not an approach to just copy and paste what's been done, but rather to really find ways to do research, to do projects that identify what works best, what gives Kenyan patients the best, safest outcomes, and find the solutions that work best within the Kenyan health infrastructure.
Thank you.
What you guys do matters, so keep it up.
Thank you. So I believe we are in the process of making history in emergency medicine. And Dr. Wachira, I don't know if you can hear me, but yeah, you are a huge role in that. And we value the work that you're doing in collaboration with most stakeholders, the likes of Dr. Masasabi and the people in the Ministry of Health. And most of the people who are listening here, the EMTs and everybody, we thank you and value for that. It could easily be us. The thing about emergency care, it should be an interest for all, because it could easily be us. I've had colleagues who have died because of road traffic accidents. And when you hear their stories, the time they go to a hospital instead of emergency services being offered, somebody thinks emergency service means you have to have very good imaging, like CT scans. They don't even stabilize you. But we have a long way to go, especially with the blood products, a very long way to go. I hope we find a solution to that. Dr. Wachira, do you want to say anything before we call it a night?
No, I think thank you, Amina, and thank you, Justin and Adam. I think collaboratively working with different stakeholders locally and also internationally, I think the work that has been done through collaborations, Brown University and other universities where Adam and Justin, I think, has been great. So I think we look forward to continuing collaborating and learning from each other to strengthen our emergency care services locally.
So thank you. Tomorrow we'll wrap up the emergency series with the state of emergency care in Kenyatta National Hospital. Dr. Sugut and Robai would be the one doing the presentation. And we have finally started the webinar for patient education, but for non-healthcare workers. So you can spread the registration. Thank you very much for joining in. Have a good night. Good night, people.
Good night.